in which the couple is counseled for all forms of contraception for family planning. So similarly, we as nephrologists, physicians also start offering all dialysis modalities to the patient in an unbiased manner. We may achieve some surprising results. So Emergent Start PD becomes a good candidate when we are counseling someone for PD in an urgent start basis. Secondly, part of the other issue that we have is that most of the deaths in CKD have doubled. If we take the statistical data, back in the 1990s, the deaths due to CKD were around 5 lakhs, that is 0.59 million. But they almost doubled in 2016 with an estimate of about 1.19 million, 11 lakhs. So in such cases, India being a place where 2/3 of the population resides in rural areas, patients being diagnosed of renal failure do not even have the opportunity to get access to dialysis. So PD can be a very good modality for them, and ESPD, again, as a short form of Emergent Start PD, can be utilized for this setup. Also, another challenge that we face, which is has an impact, is that the patients called crash landers. Basically, those patients who are the late referred patients, who, especially in the ICU, who need PD, who need dialysis on an urgent basis. So, Emergent Start PD, because of the timing, is as good as hemodialysis. Now, coming to the survival benefit, there was a study by Wong et al. Where they compared survival benefit of PD patients and HD patients. And these patients were eligible for both the modalities of dialysis. So what they did was 926 hemodialysis patients and 450 PD patients, they were analyzed. And what they found was that the baseline PD patients had a higher serum albumin, serum hemoglobin, and the cerebrovascular accidents were less, and even congestive heart failure was less in these patients. But all in all, the study concluded that both the therapies have an equal survival benefit. There's no upper hand between the two. So again, we should promote Emergent Start PD. And of course, with the global burden of renal failure, with the pandemic, having a training for dialysis which can be given promptly would help us in the future. So making it possible, the way we promote hemodialysis, PD, what we do at our center is just the same. I mean, there's no difference. We counsel the patient, we put in central venous catheter, the hemodialysis is done by the dialysis technician. So similarly, Emergent Start PD follows the same route. We counsel the patient, PD catheter is put in the abdomen. Instead, we enter the vascular space in hemodialysis, we enter abdominal space in the peritoneal dialysis. So that's about how we can make this more popular. To come to real-time stories about Emergent Start PDs, the fact that we are doing all our PD initiations are Emergent Start PDs. Since I've joined NIAXA, I think not once have I seen that we've initiated PD after 14 days. We insert the catheter and within 24 hours, PD is initiated. On an average, we are doing around 3 to 4 PD catheter insertions a month. Now, our approach is pretty much standard. What we do is when a patient who is in need is counseled by the nephrologist, and once they show willingness for dialysis for peritoneal dialysis, they're again counseled by the PD technician. So that, I think, does make a difference for patients receiving the modality easily. Secondly, as the standard, patient is given 1 gram of vancomycin 1 hour prior to catheter insertion. So all catheters are placed in the operating theater, operation theater, because it's an aseptic environment, it's a controlled environment. Irrespective of how the patient is, we prefer inserting the catheter in the operating room. The catheter is inserted by the nephrologist. As Dr. Vineet sir and Dr. Bharat sir mentioned, there's no superiority between two catheters. At our center, we use the double cuff straight Tenkoff catheter. And what helps emergent start PD becoming a success is that while inserting the PD catheter, as even Dr. Balasubramanian sir said, fixing the catheter cuff makes the job half done, because that will prevent pericatheter leaks. So while doing the catheter insertion, this proximal cuff that is inserted, we take a purse string suture in the subcutaneous tunnel, and that probably snugs the catheter well and prevents pericatheter leaks. The other factor that also helps emergent start PD is if we have minimal incision sizes for insertion as well as the exit, and if we don't use suture material for the exit, the chance that we again prevent peritonitis in such patients. Coming to the final emergent start PD initiation. So what we do is, it's a bedside automated PD. What is the unique part about emergent start peritoneal dialysis? All the PDs are done on a cycler. None of them, we have not attempted doing them on manual, because the data which has previously been studied is all on the manual PD, and that probably has caused alarming numbers, which has caused fear amongst us to avoid PD on an urgent basis or emergent basis. So secondly, the total PD fluid volume that we administer in the crucial first 10 days in emergent PD is around 10 liters through the cycler. One cycle is around 500 to 1000 ml. The total duration of therapy is 8 to 10 hours, and the dwell time being 30 to 45 minutes per cycle as needed. Minimum 7 days are given for the patient to do, for the PD to happen on automated cycler and not manual. After we are sure that there are no pericatheter leaks, no complications, the catheter flow is good, we start training the patient for manual peritoneal dialysis, or if he can continue automated as per his or her choice. And the dwell volumes are also invariably, we can, depending on the body surface area of the patient, we can keep them between 500 to 1 liter. But what will prevent pericatheter leaks is a low APD dwell volume. Lastly, tackling and overcoming PD-related fears, especially for emergent start PD, the most dreaded complication is peritonitis and of course pericatheter leak, because if that happens, then we just fumble and just switch to HD to go ahead with the patient. So with pericatheter leak, prevention, as I said earlier, small incision for the insertion and exit side. There should be a purse string suture for the proximal cuff, which will help. It should not be too tight to, throttle like the neck of the catheter, but it should snugly fit in the rectus sheath. Third thing is low volume automated peritoneal dialysis. Lowest concentration of dextrose has also helped in pericatheter leaks. It basically reduces abdominal pressure. So the whole funda is that you keep a balance of intra-abdominal pressure in a well manner so that pericatheter leak is avoided. And also lastly, supine position while doing APD will also prevent pericatheter leaks. Now, coming to the difficult patient where, suppose the patient has a severe hyperkalemia, severe metabolic acidosis, there's a night admission, or maybe it's a hypocatabolic patient. In such cases, like in this one, we use the bimodal approach, in which the patient is initiated on hemodialysis, and 1 to 3 sessions are done, patient is stabilized, and then we transition him on emergent start PD. And then that goes on smoothly, we promptly remove the central venous catheter. Third, lastly, preventing peritonitis is another whole chapter in itself. But I think antibiotic prophylaxis and good catheter placement technique, especially for emergent start PD, will make the whole difference for the program to be a success. Lastly, I think if our generation and the coming generation promotes peritoneal dialysis in a manner which everyone here is so positive about, PD should be a good option for emergent start PD should be a good option for urgent start dialysis. And as in the words of Robert Frost, PD is the road less traveled, but I think it will make a lot of difference in the future. Thank you.
Thank you, Dr. Purva. It was a great presentation. We have been mentioning about emergent start, and today we have learned, how to go about it without getting into trouble. I welcome Dr. Hemant, who has joined late, and for our friends here, he has been